Good afternoon. My name is Wellington Hsu, and I practice at Northwestern Memorial Hospital. And it is a pleasure for me to be part of the virtual ICL for the CSRS this year. My topic will be implant technology using different material properties to create structural cages for the cervical spine. I do have a number of disclosures that are listed on this slide. The most pertinent disclosure is the fact that I receive royalties for a 3D printed titanium cage, but this is for the lumbar spine and there are no cervical spine applications. There are a variety of applications for fusion technology when it comes to structural cages, and in the cervical spine, a discectomy and fusion construct is a very common procedure. Historically, there have been a number of materials that have been available that surgeons can choose from, ranging from tantalum to allograft to titanium. But as surgeons, we need to recognize that it's not just the material that's important, but also how the surface is constructed and the overall construction of the actual device. When one looks at cage design and going beyond just the biomaterial, the interior and exterior design is important when it comes to insertion, biomechanical strength, and eventual osseointegration. Surface treatments are available that range from chemical, mechanical, and different types of porosity type mechanisms. And then finally, we are also seeing products on the market that have different coating methods, including plasma spray, grip blasting, and vapor deposition. Historically, 30 or 40 years ago, we only had one choice, and that was a fibular allograft that we would fill the chamber with a product or a substance of our choice. And 10 years later came silicon nitride, which is a material that was first used in the lumbar spine in the 1980s. In 2000, we started to see machined allograft that took advantage of both cortical and cancellous components of bone and led to the ease of insertion. In the mid-2000s, we saw a rise in peak cage use, not only for the lumbar, but also the cervical spine. And this is about the same time when we started to see tantalum, which was which caught a lot of popularity with its surface friction and insertion into the cervical region as well. And then most recently, a few years ago, the first 3D printed titanium cage hit the market. And there are a number of products on the market today that surgeons can use for an ACDF construct. One of the first characteristics of a biomaterial that a surgeon should recognize is the Young's modulus of each of the materials. So on one end, where peak is very close to bone in terms of the Young's modulus, tantalum on the other end is much stiffer. So what this leads to is the possibility of subsidence, and subsidence can then lead to either non-union or collapse of the foramen after surgery. Tantalum is a material that was more popular about a decade ago. It does have the highest coefficient of friction, which many surgeons prefer, has a low elastic, a high elastic modulus that does not match well with bone and can lead to high rates of subsidence. The use of tantalum cages have created a number of problems and stereotypes against metal cages with the use in the past, including radiographic footprint, design that precludes it from use in certain areas, such as or areas that would require nerve root retraction or being close to the neural elements. Subsidence has been described with this cage, which then leads to cage migration. And then finally, imaging artifact is very challenging with the implantation of this cage and the need for imaging thereafter. Ceramics as a whole has a number of components, including both alumina and silicon nitride. This is a material that is hydrophilic, that is negatively charged, and can increase cell and protein adhesion when compared to other materials. There are superior strength properties when it is compared to pure titanium, including strength and load to failure. And there is decreased artifact on advanced imaging, such as CT scan, as you can see with this example. However, the evidence behind silicon nitride for the cervical region is sparse. And the best data that we have available compare silicon nitride to PEEK cages and conclude that there is really no difference in fusion and or subsidence rate. There are no superiority studies, and it's difficult to determine whether or not the integration of this component is real when it comes to in vivo use. Titanium is a biocompatible and inert material that promotes the ingrowth of bone, and does by far have the best imaging artifact profile when it is compared to all different kinds of metals. And if one were to use pure titanium, there are inferior biomechanical properties such as fatigue, performance, stress notching, and brittleness. When we use it in vivo, alloys are used which improve upon these characteristics. The body of evidence for titanium and bone healing is undeniable. Whether one uses titanium foam or looks at in vitro or in vivo data, it is clear that cells like titanium, and this surface also increases gene expression when it comes to osteogenicity. Finally, PEEK is a thermoplastic polymer that is stronger than most metals, has the lowest Young's modulus, and has the most similar stiffness to bone. So if subsidence is an issue, PEEK as a material will inherently create less subsidence. There is no imaging artifact, but on the flip side, there are poor bone growth characteristics. Human mesenchymal stem cells do not like PEEK. Cells are upregulated that lead to fibrous tissue deposition around PEEK implants, and this can lead to the halo effect that we see not only in the cervical but also in the lumbar region. The use of PEEK cages also has led to different qualifying factors to assess a fusion. On the left side here, you can see that a PEEK cage can lead to bony bridging on a CT scan, but then on the right, one can see that there is still motion within the interspinous spaces. So it begs the question, even if bone forms within a PEEK cage, are you really getting a fusion? And this indicates here that you still have motion with bony bridging with a cage. So with a PEEK cage, the flexion extension views are better to be used for analysis for fusion rather than a CT scan. From a cost-effective standpoint, Dr. Khan and his research group has looked at single-level ACDFs with autograft, allograft, and PEEK, and have concluded that PEEK cages may lead to the greatest estimated costs and need for costs in order to reach the same type of clinical outcomes, which makes some sense because the PEEK cage itself in many institutions can lead to a greater amount of cost for the patient. And then systematic literature review has shown that allograft has the lowest cost with similar fusion rates and clinical outcomes when compared to PEEK and other types of materials. But we know that with the use of allografts, pseudoarthroses still happen. And the large reason is because these grafts can resorb, and if they resorb, then we lose stability at that level. As far as osseointegration is concerned, there are many studies that have compared titanium to PEEK, and these studies illustrate that it's not just the material of titanium that is important, but also the surface and the amount of porosity that we see. The more porosity that you see with PEEK, the better the integration is compared to pure material, and the same goes for titanium. And when one looks at the osteoblastic activity on a variety of surfaces, including smooth titanium, rough titanium, and PEEK, there's no question that roughened titanium performs the best in an in vitro setting. This is consistent with what we see in an in vivo setting as well, where PEEK cages lead to inherent micromotion that then leads to a hypertrophic type of callus that we see with fusion, whereas titanium can often provide, with the friction, immediate stability. We see more of a uniform healing, much similar to that of an ORIF of a fracture from bone. Additive manufacturing creates a number of advantages in order to create structural cages that Dr. Anderson will be talking about in terms of being able to create complex designs. But there are some limitations with the material that we use in strength, and there's some variability from the machines that are created. Surface modifications have led to increased osseointegration, which include both calcium ion implantation, hydroxyapatite coating, and there are mechanical alterations that have been described, including grip blasting and acid etching. All of these applications have goals in mind, including increasing the surface area, enhancing bony growth, and lowering the projected elastic modulus so that the surface itself can lead to hopefully less subsidence. There are two major ways in which materials can be coated, including plasma spraying, which melts materials sprayed to the surface, uses a plasma jet at high temperatures, but there is incomplete bonding. Vapor deposition has a more of a complete bonding process, but it uses thin films, is more corrosion resistant, but is somewhat limited in the geometry of the structure that can be coated. We know that if you coat something like PEEK with titanium, you should get better shear strength and better osseointegration when compared to PEEK alone. But we also know that coating these materials, because of the incomplete bonding, can lead to a delamination of this coating when we insert the cages under friction, and this can be seen with this in vitro study. When it comes to osseointegration, again, to reiterate, it's important not only for the material that you use, but also the surface in which it has been created and the construction of the actual device. On one end, the least amount of osseointegration can be seen with PEEK, and this is supported by the evidence-based literature. And on the opposite end, the greatest amount of integration can be seen likely with porous titanium allograft. Porous PEEK, silicon nitride, and pure titanium all probably lie within the center of in some way, shape, or form. And one could argue what the actual relative performance is to each. In terms of asking what material should I use, you should ask the question, what do you want the material to do for you? When choosing a car, you have to recognize what you already have, what you want it to do, and what the goals are for that particular vehicle. And for cage, you have to ask yourself, what are you willing to accept? If your surgical technique requires durability, then your PEEK spacer may have the best interface between the inserter. But then if fusion rates is really what you're looking for, then the material on the surface can do much better than what we see with PEEK cages. And to conclude, there are unmet needs in spine surgery because we have cages that, we wish to create cages that resorb, subside, and are non-integrative. We want to be able to create cages that solve these problems. These technology will hopefully lead to standalone cages that lead to cost-effective solutions, and we believe that novel biomaterials are the way to go. Thank you very much.